I'm Matt Stanford. I am the CEO of the Hope and Healing Center and Institute, and welcome. We're going to go through our Empower training tonight, and I'll explain where that all fits into a broader set of trainings that we do in faith communities around the Houston area and why we do that. So do understand that the training that you're going to be going through tonight is the initial training that's done in faith communities, but we're going to learn about the 4 R's, which I'll go over, and hopefully you'll be a little bit better equipped to deal with mental health issues in those that you encounter moving forward from here. So to begin with, the Hope and Healing Center basically does 4 things. We offer a comprehensive mental health center here. We treat individuals with serious mental illness. Pretty much anything you would know as a mental illness is a serious mental illness, with perhaps the exception of addiction is not considered a serious mental illness, but there is no unserious or not serious mental illness. That's kind of an odd term, but schizophrenia, bipolar disorder, post-traumatic stress disorder, depression, anxiety disorders, you name it, that's what we treat. We don't do counseling issues, but we treat people that have mental disorders. We have several programs for them: cognitive behavior therapy program, dialectical behavior therapy program. They receive case management. They also receive psychiatry while they're in our programs. We also offer 40 support groups a week for all types of mental health problems, all types of addiction, and all of our services are free. And so people come from all over the city, 220 zip codes last year. Between the support groups and individual services, about 800 clients a week. We also, as you could see, have educational programs. This would count as an educational program, although it's actually part of our training. But we have about 40 educational programs a year, as well as continuing ed credits for individuals that are mental health care providers. We also have a research institute where PhDs like myself are doing research around different areas of mental health. And then also we have our training programs. And the Gateway to Hope is a training program that we offer to faith communities. And you might ask, well, why are you interested in offering mental health training to faith communities? Well, in the United States, individuals in psychological distress are more likely to go to a clergy before they go to a mental health care provider or a physician. That is a statistic that works for anyone in the general population. You don't have to be someone of faith. You don't even have to be affiliated with a faith community. They're more likely to engage a faith community or someone in that faith community, a clergy. And if you think about it, we'll talk about some of the barriers to mental health care, but it's easily accessible. There's no stigma associated with it. Many times, the individual doesn't even realize they're dealing with a mental health problem. They just know they're dealing with a problem. And where else to go? Where better to go than a faith community of whatever tradition where people are supposed to care for you. And so this is a very interesting statistic. It was found by the National Institutes of Health. It's been replicated many times. The problem is faith communities are ill-equipped to deal with these issues, and they simply don't recognize them. You kind of almost have the extremes. You have some faith leaders that are like overtrained in mental health, like they might have licensures and lots of degrees after their name, or they're just they couldn't spell mental disorder. I mean, it's on these two ends, and believe me, this is more common. But why would we expect them to know how to do that anyway? That's not really what they were hired for. So we go into faith communities and want to equip them to be able to deal with those issues. And the reason is a second statistic, and that is a majority of people in the United States with mental health problems never receive any treatment. It's a disturbing statistic. As I was just telling a group I met with this afternoon, I worked in Libya on and off for 3 or 4 years. And, Libya is just barely not, and in many ways is a third world country. And for me to say that they don't have a functioning mental health care system wouldn't shock anybody, okay? But to say we don't have a functioning mental health care system probably would shock you. But the reality is a majority of the people with the problems that system is supposed to take care of never receive any treatment. And that's pretty disturbing. We'll talk a lot about that as we go through the night. So I'm going to just jump through this one just so I can stay on time. So here are 4 R's tonight. The 4 R's that we're going to learn. We're going to learn how to relate to those with mental health challenges and their families. So how do you talk to somebody that is in a crisis? How do you talk to somebody that is distressed so that you actually can have an interaction with them and move forward and make some progress? We're going to learn how to recognize mental health disorders. We're going to learn how to make a referral. Who do you send them to? So it's one thing to say, oh, I think this guy has some kind of mental health issue going on. It's a whole nother idea of knowing what to do with that, okay? And then finally, how do you set up some restorative programs within a faith community that are both therapeutic and healing for those that have mental health problems and their families? I will tell you that it's easy, it's simple, it's not as complicated as we've made it, okay? You don't have to know about a bunch of, I have a PhD in neuroscience, you don't have to have that, okay? It's very, very simple, okay? So, first, let's talk about how to relate to somebody with mental health and kind of mental health issues. A couple of thoughts or a couple of questions that we're going to kind of keep in mind as we go through is, when someone says that, I want to relate to people with mental health problems, what are the first thoughts that go through your mind? If you're like most of the groups that I've presented to, then, fear, concern, lack of understanding, those types of things are what go through your mind. Because we have stigmatized people with mental health problems so much, and we're going to talk about that. And then what does mental health mean to you, and how you define mental health, whatever that is, really a lot of times kind of sets you on the path for how you're going to engage somebody with a mental health issue. So let's look at 4 different views of mental health, all right? So 1, psychoses or chronic mental illness, so like schizophrenia, major depressive disorder, bipolar disorder. In fact, I just said a minute ago, serious mental illness. So that is certainly a way to define mental health, okay? It's a narrow way, but it is a way. It is not wrong. It's perhaps incomplete, might we say, okay? So, but oftentimes here at the Hope and Healing Center on a daily basis, since we're dealing with people that have disorders, or when you're in the university setting, you're in a college setting, you take abnormal psychology and you only talk about the disorders. But now we also have classes like positive psychology, which are about the positive attributes of thinking and cognitive processing, like gratitude and forgiveness and thankfulness. And you don't normally hear us on a daily basis talk about those here because nobody comes here because they're too grateful. And that's kind of funny to think about that way, but they come here because they're delusional or they have anxiety, so we tend to talk about the more abnormal aspects, but that's one definition. Broader set of emotional concerns that may or may not be diagnosable. So severe anxiety, stress, trauma. So you might think about it in a non-disordered way, perhaps, because we all know what it is to be stressed. I'm sure everyone was stressed last night. I flooded in Harvey, okay? So my wife and I were sitting on the couch, had the TV on, and the big maps up, when it's all yellow and red, that's always bad, right? And so, my son walked in, he came home from work, and he was soaked because he came in, from his car, and he walked in, he said, wow, this reminds me of Harvey night, because we're both sitting on the couch, and it was dark outside, and this terrible weather radar up. And I said, well, yeah, it just going to have that sense about it. But I imagine that he had a little bit of an anxiety, like, well, should I be worried about, he's 17. He doesn't know if there's 8 feet of water outside or 2 inches of water. He doesn't care. But should I be concerned about that? So we all know what these normal kind of subclinical levels of emotional expression and feelings are. So that's certainly also an accurate description of mental health, perhaps, again, a little narrower than it should be. Everyday ups and downs experienced by the general public. So this would be more related to circumstances. So a person gets divorced. We know it's not uncommon for them to need some counseling, or a spouse passes away, or they lose a job, or different types of things that might happen. So you go and you get some counseling. So you can see here, again, negative life events or experiences. We certainly could define it that way, a little narrower. And then finally, a state of well-being in which every individual realizes their own potential, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to the community. Now you see there's no negative aspect there. There's just a description of potential, what you can be. That is probably the best definition of mental health that is, in a sense, all the others could be part of that, okay? That's how we need to think about mental health. We need to kind of get away from what we tend to do, I think, mainly is go after the first one. When we're talking about mental health issues, we usually are talking about people that are disordered and people that, in a sense, whether we say it or not, are a problem to us in some way. They're a problem because they're having problems. We have to care for them. They're a problem because they're making noise. They're a problem, whatever. But that's what we tend to think of. And really need to think about it more as the last one here. And the reason we need to do that is we're all on, this isn't an us and them kind of thing. This is a we. We're all on the same continuum. On this, everyone in here, including myself, is on this continuum right here. And I would suggest that given the number of people in here, it's likely that there's somebody at virtually every point along this continuum. And you might say, well, is there someone? I'm sure there's somebody in here with a mental disorder, and I'm sure it's just being well managed, you know? And so you can see nobody, I promise you, nobody's down here on this perfect end where you have perfect mental health, because that doesn't exist, okay? But you could be flourishing, you could be doing well, but we all have stressors in our lives. We all have anxieties in our lives, things like that. But there could be plenty of people over on the other end, but we're all on here. Now, most of us move fairly regularly on here, and we'll have a tendency to move kind of within the middle, back and forth within the middle. So we might be having a really good day. We might have a negative experience that kind of moves us that way. We might become overly anxious or stressed or overwhelmed by a circumstance, and we have to get some counseling, go to a counselor, someone who deals with people with problems. Or potentially, we may cross over a line where we actually have to go and see a mental health care provider that deals with mental illness, okay? And so when someone goes to a counselor, you're not saying they have mental illness. You're just saying that they have a level of distress or a level of concern that they need someone to walk them through that issue. When we say mental illness, we're talking about a disorder. We're talking about a person becoming non-functional, and we'll talk about that some more. So again, remember, it's an us issue or a we issue. It's not them and us. It's just us, all of us. So we're all on here. You're going to meet people all on that your lifetime. You're going to be on there. But remember, we can move. Sometimes we need help to move. Sometimes we're resilient and we can move on our own over time. And I think that's important to remember as well. I think a lot of times people think about it as buckets. So there's the mental illness bucket and there's the normal bucket. And so if you're not in the normal bucket, you're in that bucket. And again, if we go back to that definition where we defined it really narrowly, we said basically it's psychosis and all these other kind of things. Well, then I guess we could say this is all the illnesses and this is someone who doesn't have the illness. But is everybody in that bucket doing great? No, we know it's a range, okay? So it's a continuum. So let's think about it that way. And that's very important in the context of our perception of people with mental health problems. It also becomes very important in how we watch for those problems, how we help others with those problems, how we make referrals for people. All right, so stigma is one of the top 2 reasons that people don't ever get any care. Okay, because there are barriers, and we'll look at those a little bit later, that keep people from getting care, and there are reasons that people do not seek care. Like they know they need help, but they do not go and get help. And stigma is one of the main reasons for that. So you're ill, but you would, in a sense, make the decision, I'm better off being ill and dealing with it myself than letting others know that I've got this problem, because the consequences of letting other people know that I have this problem is going to, really look poorly on me. So people don't like to go into a psychiatrist's office, a psychiatric clinic. They would, again, much more likely go to a pastor or a rabbi to talk to a person at the faith community. Because, St. Martin's is next door. You could walk in the door of St. Martin's, you'd be going in there for anything. Who knows what you're going in there for? I doubt people sit out here in the parking lot and go, yeah, that one's mental illness right there. I bet that one's mental illness. But, I go over to the psychiatry department at Baylor all the time. I have an appointment over there. You don't have to guess why somebody's walking in the psychiatry department of Baylor. If they don't work there, they're going there for services. Now, there's nothing wrong with that, obviously, but as a society, we're not at that level. We're just not at that level. So stigma does put us into that us and them kind of category. And as I said, it's one of the top reasons. The 2 top reasons that people do not get care: finances and stigma. And so I think faith communities, again, while logistically they're where people are going, they also are functionally, the way they're set up, a place without an obvious stigma. So they are another great opportunity for us to go in there and train and to get people into care, okay? So I want you to just kind of think about these questions for a minute. First, the first one, what stigma exists within our society as a whole? So what, if you're brave and you want to just blurt something out here for a minute, so what is something that you know is a stigma associated? You know it's not true, but yeah, I'm not saying when you say it out loud that you mean that you believe that. I'm just saying, what's something, just one thing that our society says about people with mental health problems? They're violent, okay? And I mean, that's the great one, because we can't get away from that. It's everywhere. It's in every movie you've ever seen. Every mentally ill person in that movie is violent. That's how they're portrayed to you. Just like, just like scientists in movies tend to be portrayed mentally ill. Dr. Frankenstein. I mean, you can go through a whole slew of them. They're portrayed as if there's something wrong with them, and then their evil schemes work their way out. So again, they're violent. So every movie, every killer is mentally ill, and I mean, they're overtly mentally ill.
And stigma is that a mentally ill person isn't knowledgeable.
Right, doesn't know anything. Absolutely doesn't know anything, can't do anything on their own, can't hold a job. A lot of times you see that. So absolutely, they're minimized. But the violence is, we see that. And we're so quick to, there's a school shooting, mental illness. Now, I'm not saying that people that have shot up schools weren't mentally ill. Plenty of them were, plenty of them weren't. People with mental illness are likely to be violent than anyone else in the general population. But that's been done 1,000,000 times over. There's no data. Now, if you start parsing it out where you take mental illness and you mix substance use with it and all this other kind of stuff, yeah, you can come up with an equation that makes people more likely to be violent. But if any of you were a substance user, you're more likely to be violent than the general population. That's just how that is. So mental illness in and of itself does not make anyone more violent than anyone else. In fact, actually, people with mental illness are more likely to be the victims of violence because they're more vulnerable than actually perpetrate violence. Again, that does not mean that, somebody hasn't walked into a place, into Aurora, Colorado and shot up a movie theater because they were schizophrenic. The problem is that we have selective attention in our media. We only show certain, do you know how many people get shot every day in the country? It's a lot, okay? I mean, I lived in New Orleans for 10 years. Somebody gets shot in a school in New Orleans, and no exaggeration, almost every day. But they're poor and black, and nobody cares. And they're not a mass shooting. That's the other thing. We define a mass shooting as 4 or more people that have been killed. The shooting that happened, was it yesterday, Colorado shooting? That is not considered a mass shooting because only one person died. Okay, so the FBI has to define it some way. So you could go and kill 3 of your family members, and that doesn't count as a mass shooting. So it's, there's a lot of other things going on that we don't ever hear about because they just don't make it into the database and stuff like that. So mental illness, just take that off the table. It's not if it was that easy, there would have only been one Columbine. There would have only been one whatever. It's easy. We'd take care of that. And then this actually should say in your faith community. So what is a stigma? That was a great one. What's a stigma that you have heard or think might exist within a faith community in relationship? Because all the same stigma in the general population exist in faith communities. But what's something special that might exist within a faith community in relationship to mental illness? Something that minimizes the person. Right, it's a sin issue, it's a faith issue, they did something wrong, God's punishing them, or they don't pray enough, now you might think, oh, that doesn't happen. That happens all the time. And you might think, oh, well, those are just people that live there. They go to church in some trailer out in the backwoods of Louisiana. Nope. No. In fact, I could get you in my car right here, and we wouldn't have to drive more than about 10 minutes, and I could take you to a church where they would tell you that. So, And I could take you to churches within the same denomination where one that said that isn't true and one said that is. We're in a very post-denominational world. So there's a lot of that. There's a lot of spiritual kind of stuff, I like to say there's a stigma in the general population, but when you get into faith communities, there's like an ugly spiritual crust that's put over it where it says, you're just weak, you're a bad Christian, or you're not you're not orthodox enough as a Jew or whatever, but it's your fault. And it's only spiritual interventions will bring you out of this. So that being said, okay, I'm going to set the stage here. We're going to come back to that. Let's talk a little bit about how would you engage somebody that was in a crisis situation or in distress. In the context of this training, which again is done for faith communities, is a lot of times people will show up at faith communities and they'll be in distress, and a lot of times they'll show up and they'll be in crisis. A very common person that we want to have at the training is the church secretary, because he or she is engaging people all the time that show up and say, I need you to pay my light bill. And then they'll say, well, we've already paid your light bill twice, we can't pay it again. And people don't like to hear that. And if they maybe have some mental illness and they're not perceiving correctly, they might explode, And again, it's not to say that they're violent, it's just that their expression might be different. And we've had that actual scenario happen. Or someone might show up. I've actually had clients here that show up in a service and disrupt the service. We have a client that used to come here that likes to get up in the pulpits of Catholic churches on Sunday morning. She's neither Catholic nor obviously not a Catholic priest, and she doesn't go to Catholic church. She just goes to a Catholic church and gets up in the pulpit. And they don't like that. As I've said, she's been drug out of some of the nicest Catholic churches in this city. And that's another sad thing. You really drag somebody out that's sick. So let's talk about what would you do? What would you do? So this is going to kind of be our outline. We're going to assess the situation. And I think that's that sounds like an obvious, but we just react. There's going to be no reaction here. There's going to be a very methodical, kind of thought out response. We're going to listen. We're going to maintain control. We're in control. We're not putting that individual in control. We're in control of the situation. Regardless of how loud they are or what they're doing, we are in control of the situation, okay? We're going to engage them, and then we're going to use this VAR, the validate, affirm, and reconcile. There's going to be a little handout on the very back of your thing that says the VAR communication tool, just a little reminder that you could take home, but I'll talk about that a little bit. So a crisis, what is a mental health crisis? Now that sounds like a given. That's like everybody might know what that is, but no. What you might call a crisis, I might not call a crisis. A crisis is serious, okay? It's around here, when we think of a crisis, we think of somebody that's in danger of harming themselves or others, okay? So in a situation where you're not in a mental health setting, you could lower the bar a little bit for it to be kind of a crisis situation, but not too much. Individual experience or perception of an event that exceeds their ability to cope with the situation. So they have, in a sense, lost control of the situation personally. They are so overwhelmed by the situation that they are no longer able to cope with this. So they could be weeping, they could be screaming, they could be on the floor in a fetal position. I mean, who knows what they're doing, but they have lost the ability to cope with whatever it is that's going on. A couple other things, their behavior may change drastically or without warning. So they could appear relatively calm one moment and the next, and they may struggle to understand what's going on. When you are in that state, you do not process information effectively, okay? So the one thing that we are not going to try to do to somebody who is in that kind of a state is to try to reason with them, okay? You cannot reason with an unreasoned mind, okay? So you're not going to say things like, well, you just need to calm down now. Because that doesn't work with children, and it's certainly not going to work with them, okay? You need to be quiet. Now, don't do that again. I mean, these are the kind of things that you're not going to worry about. Now, within the context of a faith community, some of the problems that we run into are this. Faith communities tend to be very calm and serene and tranquil environments, okay? And so they don't like people yelling. I mean, imagine that. They don't like people moving around a lot or making a lot of noise. And so the tendency well, I guess they tend to be this way, and that is trying to get the person to be quiet so that they don't disrupt the other things that are going on, okay? We're not going to worry about that. You are unconcerned about anything else that's going around you. You are only concerned about the person in front of you, okay? So if they are in the front office and they're making lots of noise and there's a Sunday school class going on, or the kids are in school, there's a school there, you're not worried about that. You're only worried about this person right here. Because if you tell them to be quiet, it's not going to do any good anyway. I'm just telling you that. That's not going to do any good. So we're going to assess the situation, okay? You're not going to panic. Just because they're yelling at you does not mean that you need to be worried. Just because someone yells at you does not mean they're going to hurt you, okay? You have to understand that, okay? You're going to determine, are they armed or violent? If there is any violence, if there is any aggression, or there is any weapon involved here, everything I'm telling you from here on out doesn't even matter, okay? Your only thing to do, your only option that I'm giving you is you immediately leave the situation and you call 911, okay? I don't care if they do have schizophrenia. When violence comes into play, you are way over your pay grade, okay? So that's it. Okay, and there's no reason for you to try to be a hero. Oh, I went to this little lecture and this guy taught me how to. No, I did not, okay? I did not, all right? You are not going to do that, okay? So I would not do that except in very rare circumstances, okay? I would get my people out and away and we would call 911, okay? So any suggestion of violence. So do you know the person? If you don't know this person, then one of the very first things you're going to ask them is what their name is, because our name is very salient to us. It's very calming, and you're going to say their name as often as you can as you're talking to them, because hearing your name is a very calming thing. Pay attention to nonverbal cues. I mean, are they right up on you? They have their fists clenched? Are they trying to back you into a corner? What are they doing? Okay. And if possible, make others aware of the situation. You do not want to be, in some back room of the faith community, all by yourself, backed into a corner, and nobody else knows you're there with this person that's screaming at you, okay? You just don't want to do that. You want to make sure that others are aware that you're okay and where you are and what's going on. So you're assessing the situation. Now, you're going to do that before you really do anything. You're not going to just start talking. You're not going to just try to start fixing, because that's what we are. We're fixers. Fix. We want to fix everything. You can't fix this. This is mental illness. You cannot fix this, okay? So you can de-escalate this situation. You can connect with the person. You can offer them some resources and help, but you can't fix probably what the core issue is that was going on here. You're just trying to calm the situation and connect with this person. So actively listen, fully concentrate on what they're saying. Now, they are saying something. Okay. Now it may be relatively incoherent. It may be spot on and clear, but they're saying something. You need to really listen. Don't try to respond. Just listen to what they're saying, even if what they're saying is incorrect. So he's saying, you said you'd pay my light bill. I don't understand why. I thought you people are supposed to love people. Why are you not paying my light bill? Okay, well, now let's just, in that scenario, that church only pays the light bill twice, okay? And he's there a third time. Now, it will do you no good to go, let me explain the rule to you, okay? There's a rule, all right? Doesn't matter, okay? Reason, no, there is no reason here. This person is in distress. This is escalating the situation. No reasoning is going to happen here, okay? Maintain eye contact. You're looking at them. Demonstrate concern. You're listening. You may nod, you may be non-judgmental. That's where you're not trying to explain to them why they're wrong, okay? Because it doesn't matter whether they're right or wrong. In their mind, in their heart, they are right. It doesn't matter whether they are in reality right or wrong. And really, are they wrong? Okay, I mean, they want their light bill paid, so they're right. They just have lost. And think about that for a minute. You want your light bill paid. Maybe you have kids at home. Maybe you have a young child, baby, and maybe it's 100 degrees today outside. You need to take care of your family. You're going to lose everything in your refrigerator. You're going to not be able to sleep tonight. Your child, maybe they're ill and they can't be in the heat. I mean, there's a lot of reasons why they really do need to get that light bill paid, and they don't understand why you won't pay it. And your rule is of no consequence at this point. Ask open-ended questions. We're going to talk about that in a minute. Paraphrase or reflect back. So we're going to come back to that in just a second. Now, I'm going to tell you how to respond in a second using the VAR approach, okay? Because I think that's the best approach. Maintain control. You want to give them room to move around. One of the things a lot of times in the faith community, people get right up on top of each other. And so we were in a faith community where we asked them, well, what would you do now? So give them this scenario. Well, I would just put my hand on their shoulder and I'd pray on them. Well, you touch them and they're going to smack you across the face. You do not touch somebody that is in distress or in a crisis. You don't touch them because that's a threat. They are responding at a very primal, instinctual level at that moment. And if you reach out and you put your hand on them, they're not processing that. You just threaten them and they're gonna react. So there's no reason to touch them. Give them plenty of room to move around. What I like to do is I like to take them outside. So now you're gonna maintain control. What you don't say is, would you like to go outside with me? Because then you just gave them control. You don't ask things like that. What you say is, I hear what you're saying, and I'm going to step outside right now and we can continue our conversation. And then you walk outside. Now, you just walk outside. If they don't follow you, they don't follow you. You just walk outside. Believe me, they'll follow you. If you're the person that they know is the one that's going to try to help them or they need to talk to, they'll follow you outside. Now you got plenty of room, you're outside, or you go into a larger area. What you want to do is just get out of a small confined area, okay? Remove spectators and triggering persons with the church secretary is a great example. If the guy, if I walk into a situation and he's yelling at the church secretary about not getting his light bill paid, his focus is on her. She is the trigger. So if I start to try to engage him, as long as she's sitting there, that conversation becomes, I don't understand why she won't, you got to get her out of there. You gotta say, hey, Susie, I think I've got this. Why don't you go to the break room for a little bit, and you just get her out of there. That in its own right will de-escalate the situation slightly, but just get others away. You also don't need a peanut gallery watching you. So while it's not a good idea, you don't want to take them into a small office and close the door. That's never helpful either, not because they're necessarily going to harm you, because now you've got them in a confined space, and nobody feels comfortable in a confined space. Particularly if they're not getting what they want. So you want to get into a larger area, but you also don't want a bunch of people around watching. Place yourself in a position to exit easily. So you always want to be between them and the door, not the other way around. Again, it's just being cautious. Don't touch them. I already said that. And just be calm. So we're going to start talking about what we say to them. This is not everything you think to do, don't do. Okay? Because it's wrong. Raise your voice. Like we all start raising our voice because if I talk louder than you, then I win. Okay? Try to reason with them, explain to them why they're wrong, like they're going to get it. Get, right up on them. It's like it's some kind of a show of dominance and that you're in charge. Telling them, you need to be quiet. Don't you know where you are? None of that works. And that is, unfortunately, kind of the top 5 list of what we're going to do, what everybody just does automatically. We do it with little kids. It doesn't work with them. So maintain control. Okay, so here again, very simple list. It's in your handout. Things to do, things to avoid. We already talked about a lot of these. Don't act fast. Don't ask permission. Don't ask why. Why are you doing this? Why are you acting like this? They don't even know why they're acting like this. So why? And you know what? Let's say they gave you just a perfectly cogent answer of why they're acting like that. Would that change anything? No. I'm acting this way because of X, Y, and Z. And then they go back to acting that way. So, don't be too calm, like you're just kind of like you're not paying attention to them, or you need to make sure that they recognize you're concerned about them. Don't try to get all up on them, become angry, and telling them to calm down. The to-do things are pretty obvious. Dress them by name. You're going to just say their name over and over. As you say, well, John, I think that's a really good point that you're making. I understand what you're saying, John. I would feel the same way. I mean, you're gonna work it in. Their names, speak in a normal voice, slow things down. It's fine to take your time. We're always in a rush. Relax body language. If they hesitate, that's when you talk. You don't talk over them. That's the other thing that we do is wrong. They're talking and you're going to interrupt them. Just let them talk. Well, they're not saying the right thing. Well, just let them say it. And they're going to hesitate. They got to take a breath. Everybody breathes. So they got to take a breath and then you say something, okay? Keep suggestions short and simple and you repeat yourself. You might say the same thing over and over, and that's okay. Sometimes you need to hear it over and over. So let's talk about this: validate, affirm, reconcile, okay? As I said, this individual is at a level right now where they basically are responding instinctually or, very primally, okay? So this is all about emotions and feelings. It's not about reason, okay? So they are expressing some emotion. In the scenario I just gave you, it's probably mostly anger, but it's also fear. Okay, the guy is fearful that he's not going to get his lights turned back on. He's not angry that he's not going to get his lights turned back on. He's angry at you for not paying for them, but he's fearful that he's not going to get them turned back on. Do you understand what I'm saying? You have to listen for that. You have to figure out what is the emotion that this individual is expressing to me. Is it fear? Is it anger? What is the emotion? Because it's that emotion that you're going to connect with. Okay, you're going to connect with them emotionally, or what we a lot of times say at a heart level. You're going to validate their feelings and experience, okay? So you'll see in that little handout, there's a couple of examples. So with that guy, I might say, hey, I really understand that you're afraid and that this situation's made you angry. I would be upset also if I didn't think I was going to have power on for my kids. Now, that's a very different response than you need to be quiet and we don't pay you light bills more than twice. And so I'm connecting with him on an emotional level. I will tell you that if you can identify the emotion correctly, you can repeat the emotion back to him and then kind of connect with him on that sense that I understand what the situation is, and it would make me feel a similar way. If that was happening to me, the situation will begin to de-escalate so quickly you won't even believe it. You won't even believe it. They will be shocked when you repeat their emotion back to them. Okay? Now, you might have to do it more than once. They might not have heard you the first time. Okay? So you're going to repeat it back to them. Now, once you make that connection, you're validating their emotions. They understand. They now know that you know how they feel. Okay? That's more important than that they know what your rule is or whatever, okay? Now you're going to affirm them. So you affirm them as a person. You say, hey, you know what? You're important to us because you've come to us for help, or you're important to God. This is a house of God, and we want to help you. You're important to us. We care for you, and we want to see what we can do to work this out. Again, I'm not saying I'm going to pay his light bill. I'm not asking you to lie to him. I'm just saying you're going to affirm him as a person. Hey, I appreciate you as a father going to these extremes to make sure that your kids have a roof and power so you can care for them. Well, that's not a lie. That's accurate, right? So you're validating them as a person. You validate them spiritually. You tell them that God cares for them. I mean, there's a lot of opportunities in a faith community, but you personally validate them as an individual, okay? So you're validating their emotion. You're affirming them as a human being or as a spiritual being. And then you're offering some reconciliation. Why don't we sit down out here on this bench? This is another way I get them outside. Or another way would be like this. I'm going to go out here. I've got my phone with me, and I'm going to go out here on the bench, and we may not be able to take care of your light bill, but I know a couple organizations that would be able to do it. So let's go sit down, and I'll pull them up, and we'll figure it out. Again, I didn't say I was paying his light bill. And I do know some other organizations that'll do that. I can sit and I can get him connected. So maybe I call one and I say, hey, I'm sending John over there, and we weren't able to pay his light bill this month, but he needs his light bill paid. And I'm going to send him over. Who is this? This is Amanda. Right, Amanda, he's coming over, and I'd like you to take care of him. That's a whole different response than what people normally get. Whole lot different. And again, it tends to be why you're in the wrong, what the rule is. You kind of need to get out of here. You need to be quiet. We can't help you. It's again, you have to narrow your focus back to it's only that person that matters at the moment. And in God's economy, that is accurate. That is what matters right now, is that person, okay? The rules and things we set up and being quiet and all this and that doesn't matter. Okay, so that's how you want to engage somebody who's going into a crisis. We're going to talk in a few minutes about suicide. We'll add in some things in there, but someone who's in that kind of agitated, escalated, kind of distressed point where you might think of this as a crisis, you can de-escalate the situation by simply following this very simple. I know it sounds so simple, but that's the thing. We make it so complicated by all the other things we do, okay? Throwing a bunch of rules out at somebody to kind of bring it all, that's very complicated. But if you start to connect with them on an emotional level, it's not. Because remember, they're primal at that point. It's all feeling, okay? Questions on that? All right, we'll go through a little bit more of that. Another big scenario is, like I said, when someone comes for faith community, someone comes in and disrupts the service. And I've even had that happen at services I've been in, where somebody comes in and they're marching around, they're making noise and stuff like that. And again, the consensus tends to be that the church or faith community in some way has put in place something to get the person out of the big room so the service can continue on. And I certainly understand why you would think that's a good thing, but it's not, because I already told you people in psychological distress are more likely to go to a faith community before they go to a mental health care provider or physician. And if somebody shows up, and they're not being violent, I'm not talking about that, but they obviously are outside the norm of being able to fit within this very structured situation that's going on. When that person came for assistance, we should assist them. And I think that's what God would have us do. I told my own church, I did the training there, and they have support groups and stuff now. And I told the staff of my own church to go through what their plan is. Their plan was, anybody hear from my church? Okay. So I don't see anybody I know. So their plan, again, very common plan, okay? I found out that my church has an off-duty police officer at each service, very common, in plain clothes, okay? If somebody comes in and disrupts the service, there's an executive pastor that goes and engages that person and asks them to come out into the lobby and to talk to them there. And I said, okay, well, what happens if he says no? Okay, and then they said, well, then we asked the plainclothes police officer to come over, stand by the executive pastor, and make it known that they're a police officer, and now would they please just come out in the lobby to talk? And okay, I said, so they say no. And they said, okay, well, at that point, we turn it over to the police officer. And I said, well, then what do you think a police officer does? They handcuff them, and they drag them out. And I said, it's not okay to drag people out of my church. I'm not okay with that, period. If they're aggressive or violent, I have no problem with that. That's fine. But a mentally ill person that came in and is disrupting some thing we made up long after the fact, but think it's been done since, Jesus walked the earth kind of thing. So I'm not okay with that. I'm not okay with that. So we got to be able to do better than that. And so that's this type of thing. Would this disrupt the service if he was engaging? Absolutely, it would disrupt the service. That's okay. I'm okay with that. I'm not okay with turning around and then trying to explain to my children why a man in handcuffs is being dragged out of the sanctuary. I'm just not okay with that. All right, so that's relating, okay? Now, a lot of this overlaps as we go through. Yes?
Would you treat that differently in a school situation, a day school?
If it was small children and they were, again, if I need to I need to get the children away so that I can even have the interaction. So I think what I would probably do is leave this individual and get the children away and then come back to engage them. I don't see that. I think it would be just as damaging to bring in law enforcement in a non-violent situation for those kids to see that because then they're just going to assume all kinds of things. But yeah, I think, it's situational. You have to be careful. Certainly younger children that can't understand, just by the loud voice, they might be fearful. So I certainly would get them away as quickly as possible. So again, we're going to go, the relate stuff comes back, as does all of this as we go through. Recognize. So how do you recognize what's going on? Now, I will tell you this to begin with. The problem or the mistake that's made in most training, in my opinion, is this. It tries to teach you diagnosis, okay? I got till 8:30, okay? I went to graduate school forever, all right? And I still don't, half the time I'm still making it up as I go, okay? I mean, it's just you learn something every day type of thing. You do not need to know diagnosis, okay? You need to know levels of distress. That's all you got to know, okay? Everybody gets distressed, okay? Some people get distressed when they get up in front of people to give a talk. Do you know what I'm saying? Some of you might be like that. You get really nervous. I could care less. You can put me in front of 10,000 people and tell me I'm going to give an hour-long talk and not tell me what to talk about, and I'll do it. It wouldn't even matter, okay? So there are other things that would cause me distress, okay? But then some people, when we're talking about psychological distress, we're talking about being far over on that continuum. I showed you the continuum of mental health, way over, okay? So once you reach a certain level of distress, a professional needs to be brought in to assist with that person, okay? So we're going to look at that. So a couple things. 1 out of every 5 adults in the U.S. in a given year meets criteria for a mental disorder, okay? That's a huge number. It's like 44, 45 million people. We almost never talk about this, okay? And I know I'm preaching to the choir because you're all here, but the reality is we just act like there are no mental health problems and everybody gets mental health care. Majority of people with mental health problems never receive any care. As I said, that's disturbing. And half of children with mental health problems never receive any care. Why are we not rioting in the streets? Majority of the insurance policies in the state of Texas for health care do not cover any mental health care. Okay? We got a parity law. Somebody just said to me the other day, I thought we had a parity law. We do have a parity law, but it has this really interesting word in it. If you offer mental health care coverage, it must be equivalent to the physical care. If you offer it. So guess what? Don't offer it. So they don't. So you have a great policy, and it covers no mental health care. So then your 28-year-old son has a psychotic break, and that's all out of pocket. So it happens all the time. 50% of all chronic mental health conditions are in place by the age of 14. So this is not a disorder of the old or adults. These are children's issues. Half of all chronic mental health problems in place by 14 years old, 3/4, 75% in place by 24 years old. So that 14 to 24, that's your big age of onset. That's why kids go off to college, they make a semester, and then they have to be pulled back. Things like that. Kids in later aspects of high school, that's the age of onset of most of these things, okay? So people with schizophrenia that are now 32 years old, they more than likely started that probably started for them when they were in their late adolescence, early adulthood. So these are disorders of the young, okay? So understand that. That's important in the context of recognition, okay? Because it gives you a time frame. Right? People are not 45 years old and all of a sudden they're psychotic. They don't just all of a sudden get schizophrenia. If you make it past 30 and you don't have schizophrenia, you are almost unlikely to ever have schizophrenia. It's probably almost impossible unless you have some odd variant that's late onset, which almost doesn't exist. Okay, so one time I got a call, 55-year-old man, and he was psychotic. Okay? Well, guess what? I know that's not. He was fine before that. All of a sudden, he deteriorated very quickly over a matter of days, and he was now psychotic. I know that is not schizophrenia. That's either a tumor, an infection, or a toxic exposure. Or early onset dementia, which 55 is a little early, but still possible. It's all it can be. Can't be anything else. So, when you know the ages of onset, when you kind of know that a lot of these things happen early, depression, that can happen at any age. 9-year-old can be very depressed. It can happen at any age. Now, more often than not happens in that range, but it can happen at any age. Anxiety issues. Anxiety disorder is the most common problem in teens. ADHD is the most common mental health problem in children, younger. All right, so fact or fiction, okay? Mental disorders are not real illnesses. Fiction, okay? Very common but myth. I've had people tell me that myself. This isn't like, I mean, these things are so, one guy said, they're so amorphous. I mean, it's not like, that you really, it's just kind of guessing. They don't really exist. Some 22-year-old business major, he was going to tell me, he's so amorphous. He's a little self-righteous, kind of thought he knew everything. But no, they're not. They're not. They're real, and we can demonstrate that. Mental disorders do not affect me. Absolutely not true. They do affect you. Whether you have one or not, whether a family member of yours has one or not, they affect you, okay? They affect you, okay? And so they affect you because they affect your relationships. They affect the economy. They affect your health care. They affect all kinds of things, okay? They affect you in the fact that right now, tonight, at the Harris County Jail, there are 2,000 to 3,000 inmates that have mental illness, and it's the largest psychiatric facility in the state. And in 44 states, that's true. The largest facility is a jail. That affects you, okay? Because they're going to all be let out, and then they're all going to go back in there. And that affects the economy, and it affects you as a human being because those individuals aren't really being cared for effectively. So it does affect you. People with mental disorders are violent and unpredictable. We already talked about that. Just not true. I mean, some are, but so are some people that don't have mental illness. So it's not so yeah, I could say that's true if I put the word some in there, just like I could put one up there that said just people are violent and unpredictable, which is true as well. Mental disorders are a result of weakness and personality flaws. People can snap out if they try hard enough. That's the secular version of the over-spiritualizing it, okay? And I've heard that too. If she just tried harder, she just needs a purpose in her life. That if she could just get it together, or, I had depression and I read through the Psalms and God took it away. Hey, you know what? Reading through the Psalms is awesome. I recommend it. It's not going to take your depression away, but I think it's awesome. So in fact, it might help you while you have depression, but it's not enough. That in no way minimizes faith. That in no way minimizes God. But I mean, would we say that somebody that had diabetes? I think reading through the Psalms when you have diabetes is a good idea. But I don't have the expectation it's going to make my pancreas work. Just like I think you should pray for healing. Absolutely. Absolutely. I believe in healing. So, but I don't say you got to pray for healing because you got a mental illness, but hey, you got cancer, so let's go down to MD Anderson and let's get some help. We'll pray for healing for that guy too on the way down to MD Anderson. So I mean, it's what we do in faith communities. We say, look, don't treat these any differently than you would treat any other illness. Whatever you do for the guy with cancer, do for the guy with a mental illness. Whatever you do with the guy for diabetes, same thing. It just, we often refer to it as the no casserole illness, mental illness. You say you've got a heart problem or you're having a baby or you had surgery, somebody will bring you a casserole in a faith community, okay? But you tell them that you got bipolar disorder or your kid has bipolar disorder, there's no casserole coming. That's true. That's very true. They're not coming. Just do the same thing. And you might say, well, casserole's not going to help anybody with, it helps a lot. Does it help people with cancer? Casseroles don't make cancer go away, but they make people feel better because they know you care. You're connecting. People with mental disorders do not really need to take medication. Again, that's one of those where you could put some people with mental disorders don't need to take medication, and some people do. And some people that don't have mental disorders certainly do not need to be taking psychiatric medication, and plenty do. There's a lot of overprescribing. The majority of people that take psychiatric medication receive it from their general practitioner, which I do not recommend. They certainly have the right to do that, and in many instances, it's been very helpful. There's just not enough follow-up. They just don't have the time and the opportunity to follow you effectively. You should go to you wouldn't let it just shows kind of the minimization of mental health as a discipline. You would not allow your primary care physician to treat you for cancer. Could they? Yeah, they can get access to all the same medication. You wouldn't let them treat you for congestive heart failure. You go to a cardiologist. Do you know what I'm saying? I mean, and they would refer you to one. So why would you not, it's the same kind of thing, So, but plenty of people just because you take a medication doesn't mean you have the illness that you're taking it for. So, yeah. True. Right. The access aspect that I talked about early on, people become desperate. And so they then will go, and I've sent people to primary care physicians when we couldn't get them into a psychiatrist. And for the initial, this person's having a problem and they need some medication. We know they need some to get them started. I'm willing to do that. For the follow-up in the long term, I've got the psychiatric appointment ready. So no, you're right. Because of some of the access issues. The other thing is, this is the irony of all this stuff, or maybe irony is not the good word, but your insurance would pay for you to go see a primary care physician and have them give you whatever for your depression, but wouldn't pay for you to go see a psychiatrist to get the same medication. There's plenty of insurances that's exactly how it is. I mean, that's ridiculous. And we put up with it. We put up with it. All right, so very clinical definition of a mental disorder. So this is more to kind of show you what you don't need to know. Clinically significant disruption of a person's thoughts, moods, behaviors, or ability to relate to others. And the last part's the most important part for you to pick up on. Severe enough to require treatment or intervention. We're not talking about somebody just being sad. I'm talking about depression, okay? I'm talking about being non-functional or dysfunctional, okay? I'm not talking about somebody who worries a lot. I worry a lot, okay? I'm talking about somebody who worries so much that they can't get to work, or they can't get anything done, or they can't do ever get their schoolwork done ever, but they worry all the time about it. So the dysfunction is what moves you over the line into disorder, okay? So being sad, your spouse died. My grandmother died last night. Hey, here I am. My grandmother died last night. She's 102 years old. Okay, she's been suffering for a long time, and it's kind of a relief that she's resting now and she's at peace. But that makes me sad. I love my grandmother, and I'll be sad for a little while. But I'm not dysfunctional. Do you know what I'm saying? I mean, look at the awesome job I'm doing right now. And so, but I mean, I'm able to come to work. I'm able to do things at a level that people around me would consider normal. Okay. That's not true when someone crosses over the line to disorder. Okay. So you got to think about that. You have to think about that, because what you've got coming at you are all kind of people saying they're depressed and anxious and all these I'm taking this medicine, I'm doing that. So you've got a whole lot of false negatives and false positives, and you just got this whole mess coming at you, okay? And we use those terms very cheaply. Everybody says they're depressed. I would never say I'm depressed, because I know what that looks like. That's a disorder. That is a serious disorder. I might say I'm anxious, but I never say I have an anxiety disorder. And so, but you have people say all the time, I'm so OCD, because they're real neat. No, I've treated people that have OCD, and that's not what you have. They are dysfunctional because it's so serious when it's not treated. Now, the good news of all this is these things are manageable. There's effective treatments for the vast majority of them. Many of them can be treated or managed to the level that it's almost like you don't even have them, just like diabetes. But you have to get the right treatments. All right, so what causes a mental disorder? It's the most common question that I'm asked. So what causes this? So I'm gonna describe it, and then I'm gonna give you, we're gonna do a little role play down here. I'm gonna show you. No, you don't have to get up and act like you have mental illness or anything. I'm gonna show you a little thing of how you can remember this. So a diathesis, which is a big fancy word, just means a vulnerability. Okay, so you have a weakness or vulnerability. We're all born with weaknesses and vulnerabilities. Okay, so which ladies in here in your family has a family member had breast cancer? Okay, you see all these ladies, okay? It's likely that everybody that just raised their hand, you have a diathesis or a vulnerability for breast cancer. Now, it's going to vary, depending on how many people in your families had that and what kind of cancer it was. But to say that many of you ladies have a heritable increase in the potential that you might get breast cancer, none of you would go, you are wrong. You would not say that, okay? Alcoholism ran in my family, okay? Thank God my father stopped that. He had an alcoholic father and a lot of alcoholic uncles, and he would never allow alcohol around anybody, okay? But to say that I have a vulnerability for addiction, I mean, you'd be a fool to say that I didn't if you saw how many of my male relatives had died from addiction, okay? Nobody argues with that, okay? So we have some vulnerability. You're born with the genes for certain mental health problems. You're born with neural systems that are abnormal or dysfunctional. It's a vulnerability. It is not that you were born and the minute you came out, you had schizophrenia. That's not what I'm saying. You came out and you may have had a greater potential for depression than I did. That doesn't mean that you're going to get depression. It just means you're more likely. You're more likely to have breast cancer than you, because you have it in your family. Does that make sense? So that's the diathesis. We're all born with it, and we all have it for mental health issues, okay? Don't think diagnosis right now. Just think mental health weaknesses. Just think of it in a very general sense, okay? Then you're born into the world, and then you are immediately just bombarded on a moment-by-moment basis with stressors, okay? Some of us are born into great families where we have plenty, and we get educated, we're safe, we never experience violence in a personal manner. Some of us are born in horrible situations where we're abused and we're in poverty and we're afraid all the time because we live in a bad neighborhood, and our parents got a divorce and our brother died when we were 12. And I mean, you know what I'm saying? There's all kinds of stressors, and some are worse than others, but we all are just kind of working our way through life, okay? Now, the combination of the vulnerability and the stressors is what causes a psychological or psychiatric disorder. Some disorders are heavily biological. They are more the vulnerability than they are the environment. But it's always a combination. So something like schizophrenia, okay? Schizophrenia is in essence a brain disorder, okay? It is very, very, very heavily biological. Very little stress of the environment. Something like depression, you can get depression different ways. You can get depression almost solely from the environment. You get depression almost solely from biology. You can get depression from 50-50 balance. It's just a different kind of disorder. Same thing with anxiety. PTSD, you're born with a vulnerability, but only when you're exposed to a traumatic event of a certain intensity would it ever manifest. If you were never exposed to that, you will never have it. So there's just a little vulnerability just waiting, and if enough of a stressor happens, it'll cause the person to have it. So you see it's a mix. People say, is it nature, nurture? It's both. But it's not the same necessarily for every illness. It's always a combination, but sometimes it's more or less the other. So when you meet somebody and they have a mental health problem, it's not their fault. They have something. It's like saying that someone's fault to having diabetes. They were born with a bad pancreas. That's it. Or they were born with a bad pancreas and they eat really bad and don't exercise. Because we can have different kinds of diabetes, right? And there can be combinations. So we never say to somebody, oh, well, I don't think that this health insurance or pay for this diabetes treatment. If he just ate better and exercised more. We do say that for mental health issues. And that's one of the reason they're able to get away with not covering it, is because they are able to get enough people to act like it's not real. So this is why it happens. So now I want to give you a demonstration of what I call the race you never want to win, okay? So just to kind of look at this. If we look on the top, the little princess and the blue there, down here where the little white line is, that's birth, okay? And then the black line is the diathesis. So what you have is a person being born, and then we've added in how much of a diathesis they have and how close it puts them to the finish line of getting a disorder, of a particular disorder. The top one's schizophrenia. So she obviously has schizophrenia in her family. If you have a parent with a mental illness, you are 5 times more likely than the general population to have a mental illness as an adult yourself. So obviously there's a heritable aspect. She probably had a schizophrenic parent. And you can see this is where she was born, but that's actually where she starts in the schizophrenia race, is where that black line is. So how much stress is it going to take in her development to push her into the green of schizophrenia? It doesn't require much. In fact, even normal levels of stress may be enough to move her to a manifestation of schizophrenia. Now look at the depression. You can see how these people are all at different points. They have different levels of a diathesis. They have different levels of a vulnerability. It must be her twin or something. It's bad that it's the same one. I didn't make it up, but she has very little vulnerability, right? So it's going to take a massive amount of environmental stress to get her to depression, okay? This guy down here, who has the perplexed look on his face, he obviously has a heavy, heavy biological load. That's what you think of as endogenous depression, that really heavy biological, very little stress will cause him. Now, could I take this girl right here as an infant and just abuse the living crud out of her for 4 or 5 years and give her all kind of mental illnesses as an adult? Absolutely, absolutely. So trauma, just takes over. You don't. It almost doesn't even matter how much. Depending on if the trauma is severe enough, it doesn't even matter how much of a diathesis you have. But some people are extremely resilient. They are, but enough trauma and you're going to get there. But do you see how with depression, which is less, it's more of an equal biology in most instances, you can see how you can start out at different points. And then it just depends on the environment you're in, okay? So when parents come to me and they feel guilty because their child, their 18-year-old child now is showing, pretty serious depression or bipolar, you got to work through with them that it's not their fault. And I'll go through this with them. It's not your fault. It has nothing to do with you. You're not responsible for the genes you passed on. They're your genes. Someone gave them to you. And I always say, unless you abused your child, this is not your fault. And I've never had anybody go, oh, yeah, I abused them. It's my fault. I've never had anybody do that. Okay, so that it helps them understand, because this, you don't know, unless you're an oncologist, you don't understand what cancer is to some extent. Just unless you're an endocrinologist, you don't understand what diabetes is. But we never talk to people with those illnesses like this. Nobody whose kid has diabetes, maybe if they had juvenile diabetes, but had diabetes as an adult, ever goes, I feel so guilty because my adult son, who's 48 years old, has diabetes. It's all my fault. You don't hear that. You do hear that with these illnesses, okay? So do you understand the race you don't want to win here? And so it's a combination of things. Now, can you do anything about your genes? No. Or your biology? No. Can't do anything about it. Can you do anything about your environment? Absolutely. The parents can have a huge impact on the environment of a child. And then you can help a person get out of that environment. But then remember that continuum? You can be down here, and with proper care and treatment, you can move back on the continuum, back into the more positive range. So just because you end up here does not mean you are trapped forever on that end of the continuum. You had a question?
What about the environment nowadays? There's so much divorce going on. And kids and parents feel so bad about that. And as an adult, I've seen how much it can affect you.
Right. Oh, it does. No, the rates of, when we just saw a presentation yesterday at our luncheon, the rates of mental health problems across the world, not just in the US, have increased by more than 50% over the last 20 years. Okay, and so they're going up through the roof. I mean, adolescents today have the same level of anxiety that was measured in prisoners in the 40s and 50s. So the expectations of society, the problems that we have in society are crushing our children. Suicide rates are going up. I mean, they really took a big upturn the last couple of years, last 3 to 5 years. We're in real trouble. But it's not because we don't have treatments. It's because no one gets treated because of all of the barriers to get to treatment. So yeah, all the things you mentioned, absolutely, that's causing problems. Now, people get divorced. I understand that. I don't think anyone likes divorce. I don't think anybody's like, it's like we're the American Divorce Club and we love divorce. It's a good thing. It's always bad. And it is damaging to everyone involved. But this plays a role in that. And just because a family gets divorced or a couple gets divorced is not enough in and of itself to cause someone to have a mental illness. It could be a contributing factor. But, that would be like saying that maybe she didn't have good enough prenatal care or something, Yeah.
I think today something that we haven't seen before is the high THC, the THC levels and the new synthetic drugs
Right.
are being used by younger kids.
Right.
And they have no genes that, kind of the history of mental illness, and all of a sudden, out of nowhere, they're developing these symptoms that are completely
Well, right. Well, individuals with high vulnerabilities that do use psychoactive substances can push themselves over the edge. And so, yeah, you have to be extremely, and then with the designer, you don't know what you're getting when you're buying something out on the street. It's laced with so much garbage. Yeah.
The symptoms are exactly the same.
Yeah, absolutely. Right. Yeah, you have to be, anytime you mix substances into this stuff, it all becomes even more murky. You got to be very, very careful. Yeah.
I was reading an article in this Hillsdale magazine on newsletter, and they were lambasting the legalization of marijuana.
Right. Yeah, I think that's ridiculous. Why would you legalize another intoxicant? Hasn't alcohol done enough? Really. We could sit here and argue about tax revenue and all that kind of stuff, but really, alcohol, it's legal. It probably shouldn't be, but it is. We tried the non-legal thing and that didn't work so well. But the thing is, come on. It's 75% of all domestic violence arrests, they're intoxicated. Why would we want to have another intoxicant out there that's legal? It's just, I don't know. It's insane to me. High risk groups. When I go into faith communities, and I say, I'll get you 1 second. When I go into faith communities and they go, okay, I'm getting it, but really, why would you want us to be involved in mental health care? I say, you're already involved in mental health care. Do you have a jail or prison ministry? Which lots of faith communities do. 64% of jail inmates, like I just told you, have a mental illness. That's a national statistic, okay? Over 50% of prison inmates. So that's just jail. Alcohol and substance users. Do you have an alcohol ministry or addiction ministry? Well, almost 50% of them nowadays also have an underlying mental health care problem. So here, when people show up here, we just assume they have an addiction. Because if you come here for schizophrenia, you come here for an addiction, I just assume you have an addiction until I figure out you don't. Survivor disasters of trauma, things like that. You send relief teams off, or Hurricane Harvey here. We did a lot of mental health work around that. A large part of that population will carry on long-term post-traumatic stress issues as a result. Okay? Faith communities are heavily involved in that. Homeless adults in shelters, almost 30% of the homeless have a serious mental illness. So faith communities are already doing this stuff. It's just they don't think about it from a mental health perspective. There's nothing wrong with offering somebody spiritual guidance, nothing wrong with offering someone physical relief, but you get hung in a cycle. How come, not the number one thing on the list of why someone's homeless is not having a home. But we have a housing first approach in Houston. So we take mentally ill guys off the street, we put them in a house, and then they set a fire to stay warm, which actually happened not too long ago, because they don't know about turning on a heater. Or they just wander off one day, and you never see them again. So, yes.
You mentioned that if you have a relative,
Mm-hmm.
father, mother with mental health problems, they get higher.
You have a 5 times more higher than the general population. No, not necessarily. It's higher for that mental illness. Mental illnesses, as far as the diagnoses go, they overlap so much that the speaker that we had yesterday, who was a at our luncheon, a Harvard medical school professor, he and I went out to dinner on Monday night. He said, I think we just shuck the whole diagnostics thing. There's so much overlap and there's so much subjectivity between, the person is struggling and some of the symptoms. Do we really have to come up with a specified name for it? And so, no, it's not. Schizophrenia, it does tend to be a little bit more likely to be schizophrenia. But if for instance, if it was you and you showed up with bipolar disorder, it's so similar to schizophrenia that, that it wouldn't be surprising. No, they're not in mental health. I've never seen generation skipping, although what you can find is a non-diagnosed generation. So someone has it and they don't have it manifest at a level where everybody notices it. And so they're able to, they're considered eccentric. You get a lot of that. And so the next generation you might see it, but it really was there. So there isn't any that really jump. All right, so distress, okay? So common symptoms of mental disorders. This is just this is a laundry list of, doom here, okay? But some of them are normal kind of stuff. Feeling sad or down. Anybody here felt sad or down before? Yeah, of course you have, but it's not normal sadness or being down, okay? How long has it lasted? How deep is it? Do you see what I'm saying? If I'm sad or down for a week or a couple of weeks about my grandmother, no one would look at that and go, he's got depression. We need to get him to a psychiatric hospital, okay? But 6 months from now, if I'm still down and I'm still talking about my poor grandmother and I can't get over it, well, then we've probably waited 3 months too long to get me, because it shouldn't go on that long, okay? And so feeling sad or down, confused thinking or reduced ability. What I'm not afraid or what I'm not concerned that you're going to miss is psychosis. If somebody came running in here and they were naked and they came down here and they started telling everybody they were Jesus, which is actually something I know, actually a case of that. But he was running around the street saying he was Jesus, naked, doing karate. And so, no, that's no joke. He really was. I think you would pick up on that, okay? And am I going to miss that? That's not normal, okay? So that's a problem. We need to get them to mental health care provider. What you're more likely to miss or more likely to present itself right in front of you and then you not see it as depression or anxiety or those types of things, of which there are subclinical aspects. We've all been sad. We've all been anxious. But I'm talking about an extreme. So you want to ask the person, how long has this been going on? Oh, it just started yesterday. Okay, well, it's not really anything to worry about yet. Oh, it has started 2 months ago, and I've been like this every day. Well, that's a problem, okay? Usually in psychiatry, things that last more than a month, 2 weeks or a month, that's almost everything, all the diagnoses, or either it's gone on for 2 weeks, and then you diagnose them, or it's gone over a month, and then you diagnose them. So you're looking for something that lasts a lot of time. And what's the depth of it? That type of thing. So here, I'm not afraid, I'm not concerned you're going to, trouble understanding relating to situations or, detachment from reality. I'm more concerned that, some guy's going to be really sad and down. He comes and sits in the pastor's office and said, I've really been drinking a lot more than I ought to be drinking. Well, now there's 2 of them up there, okay? And that's a concern. And so, unfortunately, what we normally do is we go, you really shouldn't be drinking that much. Well, we're not. Why is he drinking? Do you know what I'm saying? Why are you so down that you're trying to cope by drinking? Do you see? So it's all about having a new awareness of not asking the questions we always ask, the dumb questions that we always ask, but to stop for a minute and say, okay, wait a minute. What's the issue here? He said he's really down and he's drinking to kind of escape. Well, how long has this been going on? Was he drinking before he was down? Why is he down? Did something happen? Do you see it's different than just say, hey, you really shouldn't be drinking that much. That's a lot. You shouldn't be drinking that much. That's the least of his worries, probably. If you take care of the sadness, the depression, the alcohol issue probably go away. So let's go to, okay, we're going to jump. So hang on with me, okay? I'm going to make it real easy for you, okay? How do we figure out who do we make a referral for? Okay, so I'm gonna do a real quick little deal on suicide, and then I'm gonna show you you got a little device in there, a little 6-item thing. I'm going to show you how to assess somebody for distress. Super easy. Anybody could do it, okay? So here's reasons you would make a referral, okay? Most of these are obvious. Person's a threat to themselves or others. Call 911. Got to do something. They're going to hurt themselves. This is not when you make a referral, okay? You call somebody, okay? Actively misusing alcohol or drugs. If somebody's actively misusing alcohol or drugs, like I just told you, almost half of people that are misusing alcohol or drugs also have an underlying mental health problem. And it's so covered over by the alcohol issues or the drug use, you need to get that person professional help. I mean, nobody in here is going to argue that it's a good thing to be an alcoholic or a drug addict. I mean, you know what I'm saying? So that's just bad in and of itself. You don't need to worry about whether it's dual diagnosis and all that. You just need to get them to help, okay? Untreated mental disorder or mental health decline, that would be somebody that you know they have a mental health problem, you know they've been managed well, things were going well, and now they're starting to decline. They're starting to fall apart. It's really starting to show up again. They may not recognize that. They may not even recognize that they've changed. That's when you want to, you may be catching that on the front end. You need to help them get to their mental health care provider. And then the last one is the one we're primarily talking about. Needs to go beyond your training or expertise. You're going to engage somebody, something's going on, and you're going to go, this is more than just he and his wife aren't getting along. I don't know what it is, but this is more than that. You might be a lay counselor at a faith community, and maybe they set you up with this guy because he said he was having some marital problems, and then you're talking to him, and you're like, this is more than just a marital problem. We need to get somebody else involved in addition to you working with him. All right, so here's our little thing. If you look in the back there, this is called the K6, okay? It's developed by a man named Kessler. That's where the K come from. It has 6 items. Genius name, genius, okay? I would have called it the Matt Stanford gets all profits from this instrument. That would be the title, but this is the CDC uses this. The CDC gives this out to a random sample of the population every year in the United States to determine the level of distress in the general population. And you might go, well, why do they want to know that? Well, if you score a 10 or higher on this scale, the likelihood that at that moment when you're scoring a 10 or higher, you meet criteria for a mental disorder is almost 100%. So they give this out every year to see what percentage of the population scores a 10 or higher. I'm going to show you that graph in just a minute. But look how simple this is, okay? You're not asking them questions about diagnosis the way I would, okay? These are questions, and what I'm not saying is you're going to go home and make 800 copies of this, and you're going to hand this out to every person you encounter that you think has a problem. You just kind of memorize it in your head. This is how you want to talk to them. So you're working with somebody. Someone shows up at your faith community, whatever, and they are telling you their story of woe and distress. Well, okay, this is over the past 30 days. So you see it has a time frame to it. Okay, so a month, like I told you, that's a pretty common time frame for mental health problems. So over the past 30 days, how often have you been so sad that nothing would cheer you up? Wouldn't that be really easy to ask somebody that in a question? And then when they answer you, they're going to use one of those. See how those are written up there, like a little most of the time? They're written in such a way that's the way people would respond. They're not going to go, oh, I think a 4 out of a 5-point scale. They're not good, but they're going to say, yeah, a little bit of the time, So, what about nervous? What about restless or fidgety? Hopeless. Now, you might be sad. Like I'm sad about my grandmother, but I'm not hopeless. I'm not worthless. Do you know what I'm saying? I don't have those feelings. So when you're struggling with depression, you're more than just sad. You have feelings of worthlessness, hopelessness. A lot of times you have a lot of nervousness because anxiety and depression go hand in hand. But so if I was to fill this out right now, which, again, it would be the last 30 days, but let's say it included the last 2 days where my grandmother's passed away. So sad, nothing cheer you up, 0. Nervous, 1. Restless or fidgety, 0. Hope was 0. That everything was an effort, 0. Worthless, 0. I got a 1. And my grandmother died. You see what I'm saying? So you really have to have something going on to score high on this. It's a very good scale. So what I want to recommend to you is this. If you encounter somebody and you're talking to them and you get a sense that they have a 6 or higher on this, I think it's time to bring a mental health care provider in. It's time to make the referral. That gives you a buffer, okay? So, you don't go, oh, maybe I didn't think of it the right way. I don't want him to get mad at me, that kind of a thing. So this is the data from 97 to 2013, and you can see, well, the thing isn't working, but it's about 3% of the population, just an average of 3% every year. It went up on that last one higher because they moved it where it is in this set of scales, and so it actually changed with a little bit of the score, but about 3%. You know what percentage of the population at any given time? 2 to 3% has a serious mental illness at any given time. It's a different statistic than the one earlier, but so that makes perfect sense. So this is how you assess distress. You don't say, are you so upset I need to call somebody? The answer is always no. Okay, that's just how. But you know what? I'm hearing what you're saying, and I'm listening to the time frame and the depth of it, and I really think it'd be important for us to have you talk to somebody else besides just me. Now, you're not sending them away. You're bringing somebody in. You're still going to be with them. Okay? You're still going to be with them. So is there, you understand that? It's distress. It's not, you're not going to say, I think you have depression. I don't know if they have depression. You don't know if they have depression. So, you're not, this is very OCD to me. No, you are in significant psychological distress, and I think it would be helpful if we connect you with a mental health care provider. That's what we're saying. All right, so now let's talk about suicide, and then we're going to specifically talk about where do you send these people? What do you do with them? So suicide is that's the far end of this here. I mean, we have a different response to somebody being suicidal than we do when we have a person that's in a lot of distress, okay? Because we're talking life and death here with suicide. So here's some facts about suicide. It's the 10th leading cause of death in the U.S. It's the second leading cause of death for adolescents. Rates have increased 25% nationally. That's horrible. Then in that period of time, 25% increase. So over 40,000 people a year in the U.S. die from suicide. Women attempt at a higher rate. Men are more successful. Anybody want to tell me why that is? So women make more attempts, but men are more successful. Men use more lethal means. What are the 2 most common ways that men try to kill themselves? Guns and hanging. Yes, somebody said it. And women, they go for the 2 worst, most ineffective ways. Pills and cutting. They're very ineffective. You can really screw up and not, in fact, most people do. They aren't able to get to kill themselves. And then the other ways, you can really screw up and you're still dead. If you mess up when you're hanging yourself, you're still dead. You just suffer a lot, but you die. Same thing with shooting. So mental illness increases risk. In fact, what you find is that of people that die by suicide, 90% plus of them were suffering with a mental health problem at the time of their death. So suicide or death as a result of suicide is the terminal end of mental illness. Mental illness is a terminal illness if untreated. Okay? I mean, people will harm themselves. Okay, so people don't just decide, this isn't Buddhist monks that have decided to protest the Vietnam War and set themselves on fire out in the middle of the street kind of thing. Yes, that has happened, okay? But more than 90% of people that die by suicide are suffering with a mental health problem at the time of their death. So it doesn't take a genius to figure out what the deal is, okay? Nearly 80% deny suicidal thoughts in their last communication. Ask the suicide question does not increase the risk, and that's going to become very important here. To talk to somebody about whether they're thinking about harming themselves makes it less likely that they will harm themselves, not more likely. Most people have this myth or this idea that if I talk to them about it, it'll put the idea in their head. That's just not true. The idea is already in their head. If you talk to them about it, they're less likely to harm themselves. So I want to just give you a real simple, what's called a QPR. Now, there's a whole training. It's like an hour and a half QPR training. And I would recommend that you do it if you ever have a chance. It's a great training. But just what QPR stands for, the first one is question. So if you're concerned that somebody is having suicidal thoughts, and usually they will communicate to you in some way that they are like, it'd be better if I'd never been born. My family would be better off if I disappeared, if I was gone. They usually say things like that. Occasionally someone says, I'm thinking about hurting myself. But usually they don't make it so overt. But they say something. It is not normal to be talking about death and dying. Just like, I wish I was dead. That's just not normal. People just don't do that, okay? So if you think someone is having those thoughts, you need to ask them. You need to say, are you thinking about hurting yourself? Okay, and I usually don't use the suicide word because people don't really respond to that, but I usually say, are you thinking about harming yourself? And if they give me some thought that they are, then I say the next difficult question, well, how would you do it? Because I have to know if they have a plan. Because fleeting thoughts of suicide are not uncommon in people with mental illness, but just putting a plan together, that's a whole nother red flag, okay? So, client says, thought guy was suicidal, well, how would you do it if you did that? Well, I was thinking about it a few weeks ago, and I think I'd hang myself, so I went to Walmart and I bought a rope and a check to make sure it would hold me. Okay, that's a bad sign. Okay, that's a very bad sign. Or at another client, he said, I'm really having a lot of suicidal thoughts. Well, how would you do it? Well, I've been putting pills away for the last 6 months of my medication. I got a whole bowl of pills. Very bad. Okay, I need that bowl of pills, seriously. And I got it. I got his dad to get it. So that's so now you've really escalated because they've given you, it's not just I have a fleeting thought of it occasionally, but I would never do it. If they say that, they're probably okay. If they say, yeah, I have thoughts of it, well, how would you do it? Well, I've got a gun. Bad sign. They've thought about it. Question, ask the questions, okay? Persuade. If you think that they are suicidal, after you've asked the questions, you're going to persuade them. You're going to talk to them about the permanency of death, the fact that people care about them. You're not really actually going to convince them, but what you're doing is you're beginning to try to distract them, is what you're doing. You're trying to distract them from the ongoing suicidal thoughts to give you an opportunity to get them to help. Okay, so you're going to begin to talk to them about how upsetting it would be to you if they committed suicide, how upset their family would be, how you care about them, what you would miss about them. You're persuading. Again, it's not the sense that you got to say the right words and you're going to talk them out of it. You're distracting. It's more, QDR probably doesn't sound as good as QPR. And so that's why, but you're distracting them. And then you're referring. And when I mean refer, I don't mean you need to talk to your mental health care provider tomorrow. I mean, you're calling 911, or if they're a friend of yours, if you're in a faith community situation, you really can't drive them to an ER because there's some liability issues. So you're either having a relative of theirs take them to the ER, or the Memorial Hermann Crisis Clinics, or the HCPC Crisis Center, or you're calling 911. And when you call 911, okay, you're going to tell the 911 operator it is a mental health problem. Okay, and you're going to say the person's right here with me. They're safe right now, but they're having these thoughts. I'm concerned that they're going to harm themselves. It's a mental health issue, because they will send a different person than if you just go, oh my gosh, you got to get over here. Somebody's going to kill themselves. That's not, that's how most people do it. And then the guys come in, guns blazing, they want to know what's going on. So you want a mental health, the sheriff's department has mental health deputies. They'll send a specially trained police officer that knows how to do assessments, all that kind of stuff. So you want to tell the operator this is a mental health issue, okay? And you're going to stay with the person until they come, okay? Now, if it's your relative or something, or your friend, then you can just drive into an ER. Now, they're going to try to talk you out of it, and then you're also going to try to talk yourself out of it, because you're going to say, oh, I don't want him to be mad at me. Well, I'd rather be mad at me than dead. That's not even to be funny. That's just fact. If I thought my friend was suicidal, I would do whatever I had to do to get him to an ER. I'd call 911 in a second. I wouldn't even think about it. And they could hate me the rest of their life, but they have a life. So now I will tell you, I've been doing this for almost 30 years, and I've engaged a lot of different people, a lot of different families. I have never, ever had somebody do this and then the person was mad at them the rest of their life. It's never happened, okay? They are not going to be mad at you the rest of their life. And if you're afraid, well, I may be wrong, maybe they're not really suicidal, you're just saying that you're concerned enough that they need to have a professional assess them. If they get to the ER and the ER decides that they aren't suicidal, that's the ER's deal. That's not your deal. You're just showing kindness and love towards this person. So that's suicide. All I'm saying is you have to act. You have to act. Don't worry about all this other stuff that I've been saying, trying to engage them and all that. That's all you do. You ask the questions. If you're still concerned, then it's 911 or someone's driving them to an ER. Okay. All right. These are those barriers I talked about. There's a whole slew of them out there. We like to talk about the 3 A's around here: accessibility, affordability, acceptability, and then kind of there's things underneath those. So, for instance, let's say you're an indigent, you don't have any insurance and no resources, and you need mental health care. Well, we have a system set up in the state of Texas. They used to be called the MHMR system, but now they all have their different names from across the different. So ours is the Harris Center, right? Anybody know where the Harris Center's main office is? It's on 59. Okay. What if you live in the 5th Ward? What if you have to go down to HCPC, which is the, Harris County Psychiatric Center. Well, that's down in the medical center, right? What if you don't have a car? How many bus changes is that when you're mentally ill? Do you see what I'm saying? I mean, so transportation can just instantaneously just keep you from even. So I give you a referral number for like the greatest psychiatrist in the world that's willing to treat you for free. But his office is in Friendswood, and you live in Cypress, and there's no bus that goes there. So see, those kind of things you got to start to think about when you make referrals. So a lot of faith communities, they have referral lists, which is great. And I'm going to talk about that in a minute. But there's a lot of problems with referral lists too, because they have to be constantly updated. What about insurance? What insurances these places take? Did you check that out? Some mental health care providers will stop taking clients for a while till their caseload goes up or down, different kind of things. So there's a lot of, accessibility. There's way too few mental health care providers. Most of the counties in the state of Texas have no mental health care providers in them. It's unbelievable. Too few facilities. So here's another one that's a great question for you. So the number's low, by the way. In the state of Texas, it's a big state, things are bigger in Texas. In the state of Texas, how many state psychiatric beds exist? Now, state psychiatric beds are beds for people who don't have the resources to pay for private beds. How many state beds exist in the state of Texas? Not jails don't count because those aren't psychiatric beds. State psychiatric beds. 2,900. 68 in Harris County. I think there are more than 68 people in Harris County, and I think there are more than 2,900 people in the state of Texas. So that's why nationwide there's 10 times more people mentally ill in jail than there are in psychiatric beds. So it's disturbing. So affordability, we already talked about that a little bit. Acceptability, tons of stigma. Cultural issues, you're over in the Asian communities, they're the worst at accessing care. Okay, the Asian Americans, only 17% of Asian Americans with a mental illness ever receive any care. They're the worst at accessing care. So, but even the best at accessing care, it's a small minority that accesses care. So, but there's some cultural things, and then just knowledge and education. A lot of people just don't. You don't know cancer, but if you've got cancer, you know where to go. Everybody knows you go to MD Anderson. Even if you. That's just what you do if you live here, okay? And so, even if you had a cardiac problem, you go find a cardiologist. But with mental health, people just don't know what to do. All right, so our current system does not work, okay? And it is not really a system. It's a set of disjointed resources that aren't interconnected. So basically, you're with your family, and most people engage the system in crisis. And they end up with a professional mental health care provider. And if that person can't handle their illness, they then get hospitalized. And then you're trapped in this cycle. They rarely ever engage any supportive services like support groups or things like that. There's very little community residential services other than inpatient, acute inpatient, which is 4 to 6 days. It's a mess. I mean, it's just absolutely horrible. There's lots of resources, but nobody uses them. It's just terrible. And we're going to talk more about that in a second. So if you wanted to make a referral list, which if you are from a faith community, I highly recommend that faith communities make a list. But you got to update it every month. You got to go back through it and make sure that everything's up to date. And you got to get a lot of information. So you got to have all kind of providers on that list. Okay. You got to know what kind of insurances they take. You got to know what kind of people they like to see, all that kind of stuff, where they are in the community, all that. You got to understand the difference between a provider. A person who has an LMFT, a licensed marriage and family therapist, does not normally treat people that have bipolar disorder. Okay, they got a licensed marriage and family therapy degree because they wanted to work with marriage and family issues. Okay, they didn't get a clinical psychology degree because they were not interested in working with mental illness. I have a friend who is LMFT. She does a lot of work with people that have bipolar disorder because she has a lot of additional training in that. But I have other friends that have LMFT, and they would never talk to me again if I sent somebody, because all they're going to do is tell that person, I can't help you, and then send them on to someone else. So you got to kind of know the difference between one provider versus another provider. And then you got to know their specialties, and some like to see this kind of client and that kind of client and different kind of stuff, and insurances and Medicare, Medicaid, all that kind of fun stuff. So it's a lot of work. I'm encouraging you in your faith communities to do it, because particularly if you have a list of people that are close within that community, so the transportation doesn't become an issue, that's a great thing. But again, it is a lot of work up front. So now I'll make it real easy for you. You have this card, okay? Y'all got these cards? You got some of these? Did everybody get one of these? They get at the end. At the end, you're going to get some of these cards, okay? It says mental and behavioral health services. We have already gone and vetted, at this point, over 1,000 providers here in Houston. We go and meet with them. We see their facility. We ask them questions. We get all this information. We know all about insurances. We know about everything there is to know about that person, okay? And it's in a big database we have, and it's searchable by zip code and whatever, okay? So the things I've told you are important, but this is even more important, because if you engage somebody and they're in distress and they need some help, you don't have to figure out where to send them. We can tell you where to send them. You give them this card and you have them call us. And this is what's going to happen. They're going to be assessed on the phone, okay? And then if their issue or story or what they're looking for is extremely complicated and we can't do it over the phone, they'll be brought in for a meeting with one of our clinicians. We will figure out what's going on. We will lay out a little plan for them, and we will give them referrals to providers that they can afford and they can access, that we've already vetted, that are near their homes, okay? We've already got it all set up, okay? Now, starting in August, anyone that calls this number will be seen, not just if it's a complex issue. We'll bring you in, see you one time, get you to the care you need. Now, we provide services here as well. So if you're a fit for the services here, we may actually offer you the service, or you could go on the waiting list or wherever. I don't know where it'll be when you call. But if they'll call this number, they will get to the specific kind of care they need. It'll cost them nothing, okay? And they don't have to come here. We can do all that over the phone, okay? They can be from Timbuktu for all I care. Doesn't matter. So, no, that's another thing. MHMR, or what we call the Harris Center now, drive up from Friendswood and see if the Harris Center will serve you. No, it's Gulf Coast Center's down there. So you cross a county line, that you're done. So we don't care, okay? We define Houston as 90 miles outside of Houston. We go way out. So we can help you find the resources, help them find the resources, okay? So this makes you a front door to the mental health care system, because when you give them that and you say when you call this person's going to help you find the care you need, I promise you that's going to happen. Everybody we refer to, we know because we've vetted them, okay? We also never give you one referral. you give you at least 3 referrals. And if for some reason you're not able to get in, you're supposed to call back and we can help you do what you need to do. So it's not an issue of whether you're going to get to care. We're going to get you to care. I mean, that's just going to happen. Now, if they call this on an off hour, there's a voicemail, they'll be called back. If they call it and for some reason someone doesn't answer because all the clinicians have a client or something, they leave a voicemail, they'll get called back either that day or the next day. So do tell them to leave the message. So seriously, this is extremely important, extremely important. I still think that's important because it's helpful to have those local networks set up. Yes?
So this service that we offer here
Mm-hmm.
is free,
Absolutely. Everything we do here is free.
but like when you get referred to something up here that you vetted,
Right?
that
That is going to require some, right. If you have, that's another thing you're going to be asked is what kind of resources you have, what kind of insurance you have. So you're going to be put onto a mental health track that you're able to afford. So if you have no resources, we deal with that every day. So we can help you get to services that are low cost or next to no cost. So that doesn't matter.
this would fit for somebody that's just on the margin of employment.
Absolutely, and it would also work for someone who's a billionaire. It doesn't matter. We get both. So it doesn't matter. Resources do not open the door to mental health care. They just don't. I mean, we see people here most people come here don't have any resources, but we see extremely affluent people here and they're having the same problems getting care. It's really disturbing to watch. All right, so now in our final part here, I'm gonna just real quickly talk about some things that can be set up in your faith community that are restorative, that make it a safe place for people with mental health care problems that actually are therapeutic for them though. And these are even things that you'll be able to do. I think a faith community offers 4 things that the secular system doesn't offer. I'm not saying that the system, mental health care system is bad. I just think it lacks some things. And I think there are 4 things that a faith community bring to the table that it needs. One is a hope that transcends circumstances. I think, faith is a tremendous hope building opportunity. And so, if you just have hope in me that I'm going to help your symptoms go away, I might get it and I might not. Okay. But, God transcends circumstances and you can have hope despite what your circumstances are. And I think that's very helpful when you're working with somebody with mental health issue. A holistic view of the person. Faith communities see people as more than just a body. And so there are more aspects of their being that can be worked on. I'll talk about that in a minute. Accessibility, we've already talked about, it's easy to get in. And then a supportive community. I mean, faith communities are healing communities. And people with mental health problems, anyone with any problem that they're struggling through, either a physical problem or whatever, they need support. And support is therapeutic. And if I have a client and they have no family and no support, I don't care what I do, they're not getting any better, okay? And so that's what support groups are all about also. But supportive community, that's what faith communities are. So just real quickly on this, as far as in the context of building hope, if you want to build hope in a person, we do a lot of work around how people perceive God in the context of their illness and how that affects their illness. If you want to help somebody with their mental health in the context of their faith, explain to them that God is engaged in their life, that he is actively involved in their life, even in the midst of their illness. Because what we find is that basically people see God in one of 4 ways based on a engagement dimension or judgment dimension. And as long as you see God as very engaged in your life, your mental health outcomes are much, much better. If you see God as critical, this unengaged, very judgmental God, that one is the one with the worst mental health outcomes. So if someone is saying to you, God's punishing me, that's why I have depression. What they're saying to you is, God's just waiting for me to mess up, but he really doesn't care about me. And the way you turn that around is you talk to them about the fact that, number 1, depression is not a punishment from God, it's an illness. And number 2, God is actively involved in your life, even in the midst of your circumstances. And so faith communities have an opportunity to really kind of turn the tables and really put them people in a position to where they are more likely to heal. Every measure I've ever used on people with critical God image in the research we've been doing has always been bottomed out. They always have the worst outcomes with that. Whereas the top 2, even authoritative, even though it's a little bit judgmental, because they feel God is engaged in their life, their mental health outcomes are way better. This other one, they just barely even believe in God, so it doesn't really matter. They believe in a deist God. He just kind of wound everything up and took off, so it doesn't really matter. It doesn't really affect them. So this is the holistic view that we take here with our care that I think faith communities bring to the table. And when I look at a person, I see that how distress or mental health problems affect them at all levels of their being, spiritual, mental, physical, relational. And as she mentioned earlier, this idea of it being a spiritual issue, I think, you've often heard people say, well, you don't want to just take, they just want you to take pills. And that's looked at as a negative. You just take pills for your, and I think it is bad if you just take pills. I mean, no pill is just going to fix it by itself. You need a broader approach than that. But we hear people say that in a negative way. Well, it's just as negative, just as wrong, and just as bad for you to go, well, you just need to pray. Because that's only focusing on one aspect of a person's being anyway. Just like pills, I guess, would just focus on the physical aspect. And so I think pills are great. I think medication's great if you need it and you're taking the right kind, but isn't that, it's the same thing for an infection, and so, there's a couple of verses I always look at. Mostly this Luke 2:52, Jesus grew in wisdom and stature and in favor with God and man. And so I kind of see the four aspects of a person there. And when we work with a client, we work with them on all levels of their being. We help let them kind of decide what they want to work on. Do they want to work on physical issues like sleep or relaxation or medication? Do they want to work on mental things like negative thinking or anger? Or, what do they want to work on? Okay. And so it gives you a whole range of things to work on. And I would just say this as an end on that part is, imagine somebody that has bipolar disorder, for instance, and they go to a psychiatrist, and the psychiatrist says, okay, well, you're going to need to take lithium and this other medication. We're going to try to control your moods, okay? Well, okay, so you kind of level their moods out. Well, do you think they have any kind of mental issues related to being a bipolar disorder? Well, of course they do. They need to be working with somebody on that. Do you think that affects a person spiritually? If they're a person of faith? Of course it does. That is God punishing me, or where was God in my illness, or whatever. Do you think that affects them relationally? Absolutely. That's the thing I see more than anything. And it's the classic, a guy is an addict, and then he finally gets sober and clean, and he comes back to his family, and he wants everybody to act like he was never an addict. And all the damage that happened in the past. It's the same thing with mental health problems. All the damage that they cause has to be resolved. And so you have to work at all these levels. The system we have right now, some pills, here's a little therapy, it's sporadic, it's some hospitalization. It's just a mess. It's just all over the place. So that's another thing that a faith community, and that's what in your faith communities you want to express to the people that are involved in these ministries. Think of a person in a very holistic way. Don't just think about them as just spiritual or just physical. If you think about them in a broader way, then you're not saying things like we said earlier, where you're just saying, oh, well, that you have that just because that's a sin, or you just don't read the Bible enough, or you don't pray enough, or whatever. Now, this is what we're trying to develop in the city, and which is a real continuum of care. And the continuum of care means that you start out at very low levels of care and you work your way up to higher levels of care. So in medicine, there's an obvious continuum. The place everybody starts is at the pharmacy. You try to take care of it yourself, and then you might go to an urgent care, or maybe a nurse, and then you might go to your primary care, and then you go to a specialist, and then so you're working your way up. There's a long way before you end up in the hospital. And once you're in the hospital, then you work your way down. Then you're in a rehab hospital, and then so you work your way down. In mental health, there's nothing like that. It's professional, provider, hospitalization, home. So we're trying to develop a set of initial contacts, open doors, like faith communities where we started. We're going to go into schools hopefully next year. And so wherever you are, that's where you access the system. So it isn't that you walked into a church and the church sent you to the system. You walked into the church and the church is connected to the system. And that's part of this training. Support groups, peer mental health coaches, where we set support groups up in those faith communities. We train peer mental health coaches, and peer is just a layman who can provide some level of evidence-based care. Then you got professionals, you got community programs like day programs or residential homes, recovery homes, and then hospitalization. So you can see the dots get smaller because fewer and fewer people are having access to that. Some people, a support group might be all they need. Some people might need more than that. But what if all you needed was a support group and you're having to go to a psychiatrist to take medicine and you're over here doing this, you're spending all this money out of pocket because you never knew that you could even go to a support group because you didn't have access to one. So you see what I'm saying? So it's kind of like a filtering system, much like the medical continuum of care that exists. So let's talk about a few things that can be done right there in a faith community. Faith communities tend to be not really accepting places for people with mental health problems. They're really rigid, and people with mental health problems a lot of times have a broader range of normality. Sermons, is an easy place to start. I mean, if you never hear anybody talk about mental health problems in a church, why would you ever share about your mental health problem? Somebody might say, you just need to pray more, or whatever. So, the Bible is full of people that are struggling with distress, and there's lots of great opportunities for sermons. Testimonies, have people get up and give testimonies. I mean, a few generations ago, you would never see anybody with an addiction give a testimony to church. Now people love to see people with addictions give testimonies, okay? They were shunned. I'm hoping that we're moving in the same direction with people with mental health problems. How wonderful it would be for a guy to get up and share about his depression and how the church had come alongside of him and now he's doing really well and his faith has grown. I mean, that's good for the congregation and for the guy, show compassion. You got to respect people. We've been talking about that all night. Dignity, engage them where they are. Invitations to prayer. Most churches have something where they either call people forward for prayer or they have a list of prayer. A lot of times you'll say, hey, if you need healing, come down. But people think of physical healing. How about say out loud, hey, if you like prayer for a mental health problem, come on down. We'd love to pray for you. Or list out, these are the things we're praying for this month. Some members have bipolar disorder. You list it out in your prayer list. You list out cancer. Why would you not list out these other things? Because you're normalizing it. People recognizing it's a normal part of human existence. So none of those cost anything, by the way. So you can talk to your pastor. They'll be happy to help out with those. None of those cost anything. Mental health related books or church bulletin inserts. The APA, during Mental Health Month, which May is Mental Health Month, they make inserts for church bulletins that are available online, or you can order them, that are just, they're kind of psychoeducational, but they're, nobody knows about them most of the time because nobody advertises them, but they're there. Mental wellness checkups. You ever been into a faith community and they had like a health fair and they check for cholesterol or blood pressure? Well, you know what? It's so easy to add in a little depression screen or an anxiety screen. It takes no time at all. Or how about that little thing I just gave you? 6 items. 6 items. And so materials from local mental health care providers. If you don't want to put a referral list together, go vet some providers yourself in your community, and then they all have little brochures. Put those in your lobby of your church office and say, hey, these are the people we recommend. They're right here. Grab a bulletin or a brochure if you want one. People then know it's safe. They know that it's someplace you feel comfortable putting that out. Workshops and guest speakers, that's part of the training that we do. We go out to the faith communities and we do it at the faith community. All right, the Gateway to Hope training is kind of a multi-part training. The Empower training is that we're doing right now, okay? We're just finishing up. We also then offer Transform training, which is where we train people in your faith community to run a set of support groups. We have the curriculum available, and that training we have it online right now, but we're going to actually put another, a little bit better version of that online training coming up hopefully this summer. But it's free. You can do it online. You can download the materials off the website. I'm going to give you the website in a minute. And we have one for people that are mentally ill, one support group for people that are caregivers of the mentally ill, and one for people who have been traumatized in some way. They're all evidence-based. They're all great. They're all faith-based. And then the Renew training is every quarter. People could come here for a 40-hour training to become a peer mental health coach. You learn all kinds of stuff, intakes, assessments, how to make referrals. I mean, you know how to run all the support groups. You know how to do a cognitive behavior therapy intervention with people one-on-one. And you become a peer mental health coach that can then go into that faith community and offer those services as a volunteer and also oversee the mental health related ministries that are there. We have all kinds of, that's also free, by the way. We have all kinds of resources. If you'll go to mentalhealthgateway.org, that's where you'll find videos of virtually every mental illness you've ever heard of that have someone with the illness, a clergy talking about it, and a mental health care provider talking about it. Downloadable resources, online training for the support groups, databases that will help you find mental health care providers. Tons of stuff there to support the faith communities, but also to help people get to care. An individual can go there as well. These are some of the resources we have. For those churches that aren't ready to start a support group yet, we have a discussion guide that goes along with a book that I wrote called Grace for the Afflicted, which is a book on mental health and faith. And so each chapter is like a different disorder. So you can do like a discussion group, like a Bible study or a small group or a Sunday school class. And you could do this 8 weeks long, and then anyone can come to that, whether they have a mental health problem or not, if they're just interested. And then out of that, you can set up a support group. And then we have support group material, like I said. Minds Transformed is for people with mental health problems. Hearts Transformed are for survivors of trauma. And Families Transformed are the caregivers of people with mental health problems. And then the Thrive curriculum is a CBT curriculum. It takes about 8 months to get through, but it's something that the mental health coaches are taught. We use it here also with our clients, but the mental health coaches are taught how to take somebody through it individually. And it reduces their symptoms. It helps them learn to manage their illness better and makes them more independent. It's cognitive behavior therapy based. Again, all of that is free. This is our main website is the hopeandhealingcenter.org, and mentalhealthgateway.org is the support website. And that is, 2 minutes over, the Empower training. So